Welcome everyone to another episode of Talk the Tingz. This is where we deal with hot button issues in the Black community. My name is Greg Burkett. I am one of your hosts for this evening. I'll be introducing our other co-host shortly. But again, I just want to welcome you all to Talk the Tingz with GIA Productions. Who is GIA Productions? GIA Productions is a performing arts group. We use the mediums of spoken word or slam poetry, drama, music, as well as dance to entertain, educate, and empower our audiences. We have performed at the Toronto Fringe Festival, which is one of the biggest, or if not the biggest, dramatic festival in Canada. We've also staged a production at the Sandbox Theatre downtown Toronto, Pieces of a Black Woman's Soul. We perform in the Toronto Public Library's Black History Month celebrations. We've also been in many community centers and local churches and schools, both in the public and Catholic school boards throughout the GTA, particularly during Black History Month. But throughout the year, we are all about empowering our community. Um, Please do make sure that you're following us on Twitter, Instagram, Facebook. Just look for GIA Productions. As well, please make sure that you do subscribe here on our YouTube channel, and make sure you check out our website as well, giawesome.com. But again, please push that subscribe button and make sure that you are able to get all the alerts so that you know when we have these programs coming up, because we've got all kinds of stuff that's going on for this month and the months to come. So first of all, let me talk a little bit about the idea of anti-Black racism and systemic racism. We're looking at anti-Black racism and systemic racism and how it impacts our community. So for anti-Black racism, I just want to break down the term really quickly, and that is basically, well, actually, let me define it. Anti-Black racism is defined as policies and practices rooted in Canadian institutions such as education, healthcare, and justice that mirror and reinforce beliefs, attitudes, prejudice, stereotyping, and/or discrimination towards people of Black or African descent. So that's basically what anti-Black racism is. And then, of course, systemic racism, it's sort of within that framework as well, where you're looking at systems such as education, healthcare, and justice, and how they deny opportunities or make opportunities difficult for individuals who are from the African diaspora. So tonight we are going to be looking at the hot button issue of um, how, again, systemic racism and anti-Black racism works in our healthcare system. Last time we looked at how it worked in our education system. This time we're looking at healthcare. So I just want to, before we get into it, I just want to actually read to you quickly. I don't know if I want to call it a case study because it's actually something that happened. So I'm just going to read this incident to you, and it just sort of gives you a backdrop of why we're going to be looking at the idea of anti-Black racism in the healthcare system. All right, so a nominated or award-nominated Canadian rapper John River watched as public attention was shifted from his music to his struggle to navigate Canada's healthcare system. River, whose real name is Matthew John Derek Hugh, walked into a GTA hospital in December of 2017, complaining about shortness of breath and severe headaches. It was the start of his years-long health nightmare that he says demonstrates how he and others like him slipped through the cracks of the healthcare system. And it sparked a lawsuit against the doctor who he alleged neglected to treat him. He said that it felt like he was stereotyped, abused, assaulted, dismissed, and humiliated by our healthcare system. They kept telling me I had anxiety or depression, and I imagined my problem. After that initial hospital visit, Rivers said he was told to come back if the pain persisted beyond 3 days. It did, so he went back to seek treatment. He says on his visit, he was accused by a triage nurse of being a drug user and faking his symptoms rather, sorry, to get narcotics. On another occasion, he was told that he was experiencing anxiety and depression, but he just wasn't educated enough to understand that the pain was all in his imagination. Finally, during another visit, a physician recommended getting a spinal tap procedure where a needle would remove a fluid sample from his spine for testing. Health workers rather warned him that the procedure came with risks and the tap could trigger a brain fluid leak and experience symptoms that would make him feel like he wanted to die. They said it was going to be the worst headache you've ever experienced in your life. You're going to feel like you're going to die, he recalls. If that happens, they said, don't panic. Just come back to the clinic in 48 hours and we'll give you a follow-up procedure called a blood patch to fix a hole that the needle left. Just one day later, River says he began experiencing those severe symptoms. He describes intense pain at the back of his neck, trouble seeing, severe sensitivity to light. He went back to the clinic and he says that he was told by the doctor, he was told rather by the clinic that the doctor who performs the procedure is on vacation and they told him to sit tight until he came back. So Rivers tried to hold on, but when the physician returned, he still wasn't given the procedure. He says he grew concerned as his symptoms worsened day by day, and his mother watched in horror as his health continued to deteriorate. He said it felt like they left him to die, and it ended up taking over 60 days later for him to get that procedure. He was frustrated with the health system, so his mom and his music team took to social media pleading for help. They were inundated with well-wishers who were outraged at his experiences. Members of the Black community who were familiar with the unconscious biases and conscious biases that exist in Canada's healthcare system sent them advice. And I want you to listen to this advice carefully. They told him that as a Black man, the way that he and his loved ones dressed at the hospital would impact the level of care that he would receive. For example, they told him not to wear a hoodie or baggy pants. They said that he should tell his mom to watch her tone or to be conscious of her tone so that she wouldn't be labeled an angry Black woman. With that advice in mind, his mother, he recalls an incident where his mother had to or was trying to button up his shirt while he lay unconscious on a stretcher so that they wouldn't think again that he was faking his symptoms and that he was a drug dealer. His mother says, "You tell me if any white mother in this country has to button up their unconscious child's shirt because they didn't want the doctors to think that their kids were selling drugs." As Rivers' ordeal persisted, his story spread nationwide, and he received support from other artists in Canada. And it's this attention that Rivers says finally led to him getting help. Nearly 3 months after he first asked for it, he received his epidural blood patch. And this procedure was supposed to be given to him within 48 hours of his initial spinal tap. He's quoted saying, "I'm lucky and fortunate that people knew me in the community. Within a very short time period, it was bureaucratically okay to give me this procedure because in my opinion, it wasn't just another Negro who walked into the hospital. Now I was a Negro with a name and a face." So a lot of times when these kinds of things happen to us, people don't believe it. But here he is saying that this was very real. This was his experience with our healthcare system. And if he had been someone else who didn't have the networks that he had, who knows what the outcome would have been. So again, tonight's topic, anti-Black racism and the healthcare system. And 2 weeks from now, we're actually be looking at Black mental health. And we're gonna have two professors of social work along with other mental health care professionals to talk the Tingz about that topic. I want to, first of all, just before we get into things, I wanted to say really quickly, thanks to Splack Printing for our t-shirts. Talk the Tingz. This is the catchphrase for our program here. And of course, when people tell you to talk the Tingz, they're telling you they want you to have a no holds barred conversation about whatever the issue is, and they're giving you license to talk the Tingz. All right, so that's what we're hoping for tonight. We're going to encourage that from our panelists to just be straight up and just let us know what's going on with the healthcare system as it pertains to our community and what we can do to ensure that we get better outcomes from our healthcare system. So with that being said, I want to encourage everyone who's watching to participate in dialogue actively in the live chat on our YouTube channel there. Make sure that you ask questions because we're going to do our best to get the questions included in the dialogue with our panelists as well. So without any further ado, I'm going to introduce our panelists and have them tell you a little bit about themselves, and then we'll get into our questions and our very lively and engaging discussion that I know we're going to have tonight. So first off, I want to introduce Cheryl McMahon. Cheryl.
Hi, everyone. My name is Cheryl McMahon. I am a registered nurse, and I currently work as an investigator and a mediator for the College of Physicians and Surgeons of Ontario.
All right, Cheryl, thank you for joining us. And Cheryl belongs to a big family that rolls about 50 deep everywhere they go. So you just can't mess with the caters. But anyways, thank you so much, Cheryl, for joining us tonight. Appreciate it. It's gonna be fun. Next up, Jeffrey B. Evans.
Hello, everyone. I'm Jeffrey B. Evans. I work in healthcare in 3 capacities, I guess: a medical imaging technologist with the 2 Toronto-based hospitals. I've also worked in medical sales for over a decade, as well as I'm currently a 4th-year nursing student as well.
All right. So Jeff is a veteran in the field, and we look forward to all of his insight. And maybe at the end of the show, he'll reveal what the B stands for. I've been wondering for many years. Jeffrey B. Evans. I don't know if it's Jeffrey Buff Evans, Jeffrey Bad Boy Evans. We'll see. Anyways, next up we have Dr. Emily Shea.
Hi, evening, everybody, or good afternoon. Emily Shea. I am a physician in both internal medicine, infectious diseases, and critical care medicine.
All right. And Emily, it's so good to see you. I remember you as a freshman at Oakwood College, or Oakwood University rather, and now seeing you blossom into this big time doctor. It's just an amazing thing to see.
Thank you.
Makes the heart well up with pride. And Emily is bringing us a different perspective because unlike Jeff and Cheryl, who are based here in the GTA, Emily is coming to us from the US, but by way of Vancouver first. So she's bringing us that West Coast flavor as well. Okay, so I want to just kick things off, and I'm going to come to Cheryl first. And the first question I want to ask Cheryl is sort of just a broad macro look at things. How does anti-Black racism manifest itself in our healthcare system today?
Well, there are many layers to an answer to that question, but I'll touch on a couple of things. And just to kind of go back to the story you told when you first opened up about Mr. Rivers, just the fact that sometimes in the healthcare system, Black people are judged solely based on what they're wearing, the outer appearance. And so often that's consciously done, and then sometimes it's unconsciously done. Like there are the conscious and unconscious biases that exist in the healthcare system as well with healthcare providers. There's also a lack of awareness of issues that specifically affect the Black community. Sometimes we talk about different, broad spectrum issues, but often they're not specifically related to the Black community. And I think that sometimes the broad education that people get does not allow them to understand the specifics that affect the Black community. So.
Wow, thank you, Natalie. Sorry, not Natalie, Cheryl. And I want, yes, I know, yes, that's the other fam. And I want to ask Emily the same thing.
Can you re-ask the question? Sorry.
Sure, not a problem. So I want, in a sort of a macro perspective, how does anti-Black racism manifest itself in our healthcare systems today?
So again, kind of piggybacking off of what Cheryl said, preconceived or implicit bias that people may hold when someone walks through the doors of an ER or a clinic, based on the way they look, based on the way they dress, based on the way their hair is, or maybe even how they smell. Unfortunately, that can affect sometimes how a patient is treated. It's unfortunate to say that, and I've witnessed it, unfortunately, more times than I'd like to admit. I think it's honestly, I think when it boils down to it, it's all due to the kind of preconceived notions that the caregivers or the care providers have of the people that they're caring for. And the providers who are acute or aware of their own implicit bias and their prejudices, those are the ones who I think will be, aware of how they are treating the patient. But the first step is being aware of your own bias.
Okay, thank you. Jeff Evans, same thing. Just quickly, how do you see it, anti-Black racism manifesting itself in our healthcare systems?
Okay, so I will piggyback on everybody's comment, but I will probably make it more specific when we say implicit bias, what that really looks like. Inequities and racism are disease equivalents. So when you think of an inequity and racism, you have to think of it's equal to a disease equivalent itself. And so the same as being diagnosed with diabetes or hypertension. So if the gatekeepers themselves have this implicit bias, already the whole issue of having what we call a systemic race-based health disparity, it starts right there. So that's really my input there. Again, if the gatekeepers themselves are, unaware or, hopefully not aware covertly, so, then it starts there. And it's a bi-directional thing as well. It's not just the gatekeepers, it's also on the part of the person seeking care. If their health literacy is also poor, that impacts their access to care. So, in not having the right language, the right positioning, the right posturing, all those things. So, but it starts with the gatekeepers because we're the ones in the position of power.
Okay, and that point about healthcare literacy, we're going to get back to that. That's the last thing I want our viewers to hear from our healthcare professionals. We want to touch on healthcare literacy. But before we go any further, I'm going to be turning the discussion over to my co-host, and I want to take some time now to introduce her. Her name is Dr. Camila McLean. Camila, how are you?
Hi, Greg. I'm good, thanks. My name is Dr. Camila McLean. I'm a naturopathic doctor out of Brampton, Ontario. And I'm just here today to help facilitate the conversation around this very important topic, because a lot of the times when we talk about anti-Black racism, a lot of it goes to police brutality, but we need to know that it is all over the place. And that's why it's so important to have these conversations and make the necessary steps to move forward. So I'm just happy to be here.
Perfect. And Camila is a member of GIA Productions. So we have doctors in our group, just so you know. All right. But Camila, I know that you have a question with regards to, well, yesterday, Global News ran this whole thing about COVID and the Black community. So go ahead, Camila, and speak on that, or ask any questions with regard to that.
So to our panelists, and I think I'll start with Jeff. How do health crises like, for example, like COVID-19, because that's what's going on right now, that pandemic, how does that impact the Black community uniquely?
Okay, yes. So it's a very good question, because what we have seen thus far is a very different state of affairs that is happening or that has happened in Canada versus the United States. In the United States, we see that the most vulnerable, being persons, African Americans, have been most affected. In Canada, we have not seen that. And I wouldn't say we have not seen that. It's simply because the race-based data has not been collected to really get a better visual on it. But certainly, I work out of the Emerge. And when you see the Black faces that show up, most times we really look at it in terms of issues of low income, issues of poverty. And this all leads to what we call chronic diseases. And these chronic diseases, when you look at what Canadians have determined as the priority, is that it's older persons, it's persons with underlying conditions, and of course, compromised immune systems. So if you put a Black person into that equation, if they fit in terms of chronic diseases, they're certainly at risk. And so we certainly see persons of color who have been impacted by COVID. But what we have not yet spoken about are the healthcare providers of color who have been impacted by COVID. But yes, certainly it's an issue of poverty, it's an issue of low income when it comes to the actual clients we're seeing, which speaks to the underlying issues, how the pandemic is being handled here.
Okay, I want to get back to that whole thing about how the healthcare providers who are people of color, how they're being impacted, because I know a lot of the personal support workers and those types of people, those are the ones that are first hit. But I just want to also toss it over to Cheryl. What are your thoughts on this? And it just doesn't have to be just COVID, but just health crises in general.
I think that we know already that, or we heard that it's disproportionately affecting the Black community, specifically COVID-19. And as Jeff mentioned, it's because of the underlying medical conditions that are prevalent in the Black community, such as diabetes, high blood pressure, things like that. I think that, we also as a community have a responsibility a little bit, because there's a lot of rumors going around and a lot of conspiracies going around, and that may stem from the distrust between the medical community and the Black community. But often, the information that's being provided is not believed even by the Black community, and so they're maybe not doing, following the recommendations or things like that. And that could also come from the fact that there's not a lot of information about COVID-19 right now. And so people don't really know what to believe or where to look for information. But I've seen it on both sides where, there's a lot of question marks in the Black community about whether or not COVID-19 is real, or, whether it's related to something else, or, so we as a community, healthcare community, have to do better at, providing the information and making the information available and understandable. And again, health literacy is a part of that. But that's, I guess, the answer.
Okay.
And just to add to what Cheryl is saying, to no discredit to public health, which has been having daily updates on the TV and the radio, but you have to also look at it in a broad, two different lens. Who are the frontline workers who are out there working, who don't have time to sit and listen to the updates? It's most times persons of color, so it's not like the information isn't reaching everyone. It's also the movement for survival in times like this, like a pandemic, often affects persons of color who have to be active to do something to survive. In this case, keep working, right?
Mm-hmm. That's very true. That's very true, because in that same global article, I think they were talking about the reason why Black people might be more disproportionately affected is because they're in those frontline worker positions. So like, as I was saying before, the PSWs, a lot of nursing people, people who are working at grocery stores, things like that. And that's what adds to the disproportionate amount of Black people and people of color that are being affected, not only just the underlying conditions.
Absolutely.
But yeah, exactly.
I think the first 5 medical workers who were diagnosed with COVID, 4 of them were Black, and the first one was Filipino, right? So,
and the first one that died was a person of color.
Right.
So, to be quite frank about that.
Okay. Emily, what do you think can be done from the healthcare perspective to support the community, the Black community in particular?
I think again, obviously this is my opinion, but what I try to do is, both with family and friends, I encourage people, ask questions. So don't just necessarily accept what the provider is telling you. If any question you have is not a silly question, so you need to ask. It's your health, it's your body. Nobody can do to your body what you don't allow them to do. But by your silence, or by your not asking questions, that kind of gives the provider permission to say, okay, this person is okay with doing this or not doing this, or okay with doing that, not doing that. So, I encourage people to ask questions, do your research, don't, there are a lot of conspiracy theories floating around. I will reference COVID. There are a lot of conspiracy theories just within the Black community floating around. Initially, when it started, it was Black people can't get infected because of the melanin in the skin. There were some other conspiracy theories that were out there, and I was appalled. It's like, what are you talking about? Who is your source? Check your source and ask questions. So don't just blindly accept, what someone is telling you, be them friend, family, or foe. I think, as I was thinking about my own education and preparing for this, I was trying to think, how many times did any of my professors in the classroom or, on the wards say to me, hey, this is what we're doing. This is who developed it, or this procedure is named after this person. And that was it. Like, there wasn't they didn't give me the back end of it. And I'm thinking about it. I was thinking, if they, a lot of the founders of medicine, if you want to put it like that, were non-Black people. They were white people. They were white men. And a lot of the things that they did were done to Black people. That's how they, developed their thing. So I kind of feel like in medical education, when we're educating medical students and nursing students, etc., say, hey, yes, this is, this procedure that is done. This is how it was developed. But these were the people that, unfortunately, this is also part of the history of medicine.
Mm-hmm. Mm-hmm. That's good. So another question is, what are the factors that impact how the Black community engages with the healthcare system? And this one, I'll just throw it out and let anybody answer who wants to answer right now. So what are the factors that impact how the Black community engages with the healthcare system?
As was mentioned earlier, I'll take this one in part. My equation is, health behaviors are linked to your health literacy, which is linked to your health outcome. And so, yes, within the Black community, it really starts with a better understanding of your person, of your body, of what health is. And I mean, there are many definitions of health, and in a nutshell, health is really a fundamental right. I mean, it's a global social right goal for everyone. And what we're talking about right now is health equity. But the person being Black cannot get to the space wherein they can get good care if they themselves have not the understanding of what that looks like. And it's because not just persons of color, it's because generally the population, most persons aren't very disciplined when it comes to their health. It takes joining the gym. We make these resolutions and we join the gym, and in no time, and it takes 21 days, I think it is, to form a habit. And so most people don't get past day 3. So it starts with that, and it's a concerted effort, but it also helps. Again, it's as I mentioned earlier, it's a bidirectional relationship. It's a partnership, because also we cannot leave the onus of a person's health on the individual. It's also a public health initiative. You know, there's a downstream and upstream to everything. So we have to have good mandates in place, good advocates in place to ensure that the public has the right access to the right information. And it could simply be, in Canada, we're made of immigrants. Persons coming from all walks of life, with language barriers, with vision impairment, hearing impairment, all these impairments and all these barriers. We have to find ways in which to reach persons with the right information so they themselves can improve their literacy. So it's not just on the part of, say, persons of color, but it's certainly from a ministry perspective as well.
And it's interesting because you're talking, the theme of advocacy is coming up a lot. And that was something that was said in the first talking about education. I think, Jeff, you mentioned it, or people needing to know what to say. Many people, I think, have mentioned it during this talk right now. And I know somebody in the chat was saying that they don't feel like our lack of knowledge or inability to use the quote unquote correct language should affect the level of care we receive. And that's true. So while I do agree, I feel like also the other side, the healthcare provider, needs to put themselves in a position where they empty themselves of all these biases. And unfortunately, those biases are sometimes put in place because of the education.
Absolutely. I believe that, because when you look at how nursing schools have been developed, you know, since 2007 to where it is now, we have 4 streams, really, you know, and you have the we call it the second entry program, which is in 2 years you become a nurse. If you have a previous degree, you could become a nurse with a 4-year generic degree, or upgrade from a practical nurse perspective. But the whole McDonaldized manufacturing of nurses and doctors as well. Doctors, I mean, Emily can speak to this because she's a physician. I can only speak to nursing thing, but how we produce our healthcare providers is also a major issue in terms of the preparedness, the reconciliation that nurses must have, or healthcare workers must have in their roles to park those non-judgmental attitudes and beliefs, to see people. I'm in the business of, I don't go to work and say, tonight I'm going to see Black patients or white patients or Indian patients. I'm in the business of people. And that's what healthcare workers are called from an empathy perspective. So it's very unfortunate. We do get, burnout, and we do have people who don't practice the reflection techniques and coping techniques that we use to be able to go to work from a very reflective perspective and a centered perspective, that we see people for who they are. But we do have it. We do have those implicit biases. We do have persons who cannot park. The issues with a person who smokes and you don't smoke. I know you got to give them a treatment, and you help them with the treatment, but you don't want to finish the full teaching because it's like in your mind they deserve what they deserve, the bad breathing they have. So again, I believe it's how we prepare our healthcare workers. And we are, even right now with COVID, we have had this year's batch of nurses fast track to be ready for the field, without finishing their full training, but it's what it is, right? That's a part of it too. The recruitment and the attrition of nurses or healthcare providers really impacts that whole composition.
Cheryl, same question to you. What are the factors that impact how the Black community engages with the healthcare system?
Many factors. I don't know if we mentioned earlier, I feel like we mentioned poverty is a big thing, because often people can't take time off of work to go access healthcare because they need to pay their bills. So often, they won't go access healthcare during the work week because they can't, make it without that day of pay or those hours of pay. So that's one factor that can impact how the Black community accesses healthcare. I mentioned earlier about the trust or the lack thereof. So often, I know, historically, like in the Caribbean community, there's a lot of, I'm sorry if you can hear that on the street, but in the Caribbean community, we tell a lot of stories, and there's a lot of, wives' tales and things passed down, traditions and traditional medicine and things like that. And there are a lot of times where, you know, people elect to use their home remedies rather than, you know, go access the system. That's part of it as well. I'm not saying there's anything wrong with that, but that is a factor in why Black people might not go to the doctor. They will drink garlic and go to sleep or rub Vicks or whatever you know, the solution is. And you know, that's what one part of it as well. I think that we need to do a better job of, you know, bridging the gap between the Black community and the healthcare system. And that goes with that has to be trust on both sides. Like, I think that, you know, in the healthcare community, because not me personally, but people that have, you know, they're implicit by it, they don't trust what Black people are saying, or they don't trust that they're being forthcoming. They don't trust that they're being honest about their symptoms. And then Black people don't trust that the healthcare system is going to take them seriously. So, you know, that inherent distrust on both sides is a factor that impacts how the Black community accesses the healthcare system as well.
Mm-hmm. Trust is huge, because even now, like, as we know, back with it just went from my head, the syphilis. And how instead of treating people, they were giving them the disease.
Yes.
And then even now in 2020, when I say they, like people in the medical community, are suggesting that COVID vaccines be started in Africa.
In Africa, yeah.
And that trust, it's frustrating. It's frustrating. And my big thing is, you know, we're not guinea pigs. But trust is a really big factor. And I agree, Cheryl, that's probably why a lot of Black people won't necessarily go to conventional medicine. I know that's why sometimes people will come to me as a naturopathic doctor, even though some of the things that we do are similar. They'll just say, you know, I just don't trust, my doctor isn't listening to me. And sometimes I've had experiences where sometimes this is the truth, that they aren't being listened to, and like different tests and changes in diet and so on and so forth improve symptoms.
I will say, though, that to that effect, there has been an issue with persons of color securing a family physician, you know, getting a family doctor.
Okay.
And that's been a part of the gap factor, is that we find persons of color accessing healthcare through clinics, through the Emerge. And then what, up until the point where we have had the UHN, or we're able to access clinical data across sites, across systems, which is really within the last, I would say, a good healthy 5 years in all of Canada. But the interoperability of healthcare is what we call it. But prior to then, what did that look like? That looks like, you know, patient X, who's Black, goes to clinic A in Markham, and then to clinic B. Nobody, they do the whole thing over and over again. Nobody speaks to each other. And then you're going to different persons all the time, different health providers all the time. There is no trust that's really built, you see, at least therapeutically speaking. So, but I think that's the tide is changing. There's been a real push to have more family physicians out there, you know, but that's been a big part of it too, that people are really managing their health through clinics and through the Emerge access ports. And again, anybody knows, you go to the clinic, you go to the Emerge, they will ask you for a family physician, because that report is typically sent to a family physician. So the whole compilation of reports have nowhere to go. And so that's what happens when the person finally meets a chronic or acute health challenge. There is no really looking at the whole cycle of care. It's very fragmented. And then that's where you get mistakes and things being repeated, and timelines, time-based medicine isn't good medicine, isn't practiced very well, because now we have to start the equation all over again to put the pieces together. So that, I think, is part of the gap for the Black community. It is improving, but it is certainly a gap. More so for the new immigrants, I would say, than it is for the first and second generation Canadians. especially new immigrants who are here, who are still trying to navigate and negotiate the healthcare system.
Can I add to that question that was asked previously about Black community engagement with the healthcare system? I think what would improve or at least help kind of starting to bridge the gap would be to have or having more providers that look like us, be they physicians or physician's assistants, nurses, et cetera, wherever they may fall on the medical care spectrum. I think someone who looks like us will, it'll, I think in a way, encourage us to, present to the clinic or, and establish a primary care physician because, hey, this person reminds me of my aunt or my uncle or my cousin, so and so. But I think on the flip side, from the provider standpoint, again, there has to be, I think, Camila, you said this, there has to be the physician still, or the provider still needs to listen. So, and listen with purpose. So not just sitting there and hearing what the patient is saying, but actually listening and engaging within a conversation with the person. I think that helps build rapport, it helps build trust, and that encourages the patient to say, hey, if I go and see Dr. McLean, she's actually going to sit down on a stool, look at me in my eyes, and we're going to have a conversation face to face. I think there are some medical schools, or I know of one medical school that actually has a program called Medicine for Greater Good, where they actually take their residents, which are the physicians in training, and they take them out into the community. So I remember reading about a situation where they had a patient who was labeled non-compliant with his health care, and that he would frequently miss appointments, et cetera, et cetera. And when they went out to see him, when they actually went to his house, they realized, hey, this guy, lives in a poor neighborhood. He has to take the bus, and the bus stop that he has to get to has no roof on it. So the appointments he was missing were actually the ones when the weather was bad. So it wasn't that he was, non-compliant with his care. He just could not, because of his circumstances, he could not get to the appointment. And I think part of the thing is understanding the circumstance, not just saying, hey, that patient is not compliant, but why are you, I see you missed a couple of appointments. Why? Tell me what's going on. What's going on with your life? How do you get here? How do you get your medication? How do you get food? Things like that. So I think looking at patients as persons, every person has, particular things that affect them, and it doesn't matter the color of their skin. It's going to affect them anyway. So trying to figure out what that is, I think, will show the patient, hey, you're actually, you have an interest in my life, not just my health, the health portion of my life, but my life as a whole. And then again, that builds some more trust between the two.
I will challenge you a little bit there, because this is about talk the things. I will
talk
say
it.
though, yes, I will talk it, because patients also know that family physicians are pressed for time. They actually have a certain amount of time they spend with patients. And so maybe one of the solutions for persons of color, and anyone really, is to, if you quite can't articulate your concerns, it might be good to, if you have a social support system, to bring somebody along with you who can help articulate that complaint for you or that issue for you, because it's a McDonaldized process. It is that the doctors and the family physicians and even in the emerge don't have enough time spent. But I love what you said, Doc, about asking the questions into social support, away from beyond just the risk behavior issues, right? It is asking those questions that will get people to be properly supported in terms of like referrals, as you mentioned, and, or even legal support, housing and that sort of thing. Because what we're seeing is that physicians are programmed to treat just the risk factors. and then there's a whole social piece to it that's left unaddressed, and then the patient ends up coming right back into the emerge, not even a couple of days later, and so I think they call it structural competency, and it's rebuilding the assessment tools, changing the language, how doctors assess, and even nurses, how they assess. And these things are important because, again, it's not just touching the illness itself, but looking at the social pieces as well.
I will agree with you. I will not dispute what you just said. I would also encourage, bring someone else with you as well. Particularly for patients who are up in age, getting older. A lot of times, I know in my own family, and I think in the Black community, especially if you come from the Caribbean, it's like, yes, doctor, whatever you say, doctor, and there's no questions asked. And then they, call me up and say, hey, the doctor said so and so. And I said, what do you mean? Well, I didn't really understand what they said, but this is what I understood. And it doesn't make sense to me. So, I always encourage family to, bring a paper and pen with you so that when you call me, you can read back to me what the physician said. So, and that's because I can't be there for my, in person for my own family. So for someone else, I would say if you have someone who can go with you, bring them with you, especially if you're an older person, so that because they may ask questions that you may not think to ask. They may understand a little bit more than you would. And so, yeah, I totally agree with having somebody else, there with them.
I just want to add to everything that both of you all said, but specifically the fact that, there's a lot of, systemic things that are going on right now in the background that people, might not be aware of with physicians, and, how much time they can spend with patients and how much time they're willing to spend with patients, because they can essentially spend as much time as they want, but how much they're willing to spend with patients. And I know that there's different models of care here in Canada, or Ontario. I can't speak about Canada. I know Ontario. We have the family health team, we have the community health centers, we have different models of care where, if you access a family physician, if you have a family physician and they're part of a family health team, often the family health team has diversity in healthcare professionals. So they might have a social worker, they might have a, physiotherapist, they might have a nurse, they might have different, a specific diabetes educator or something like that. So there are different ways in which our system is trying, I think, to do better with being able to look at the person holistically, because, the physician is, as Jeff mentioned, trained to look at the person as a disease. Like, this is what is wrong. What are the objective things that I can figure out, blood work and these things. They're not always asking those social support questions, and not everybody has somebody that can go with them, or not everybody has the ability to write something down. So, often with those types of patients, if that's known, then, they're encouraged to join a family health team or a community health center, because there are other providers that are there to kind of fill in the gaps. The physician, at this time is saying they don't have the time to fill in because they're overwhelmed with the number of patients or whatever. So, it goes both ways. I think there's, if the patient can bring somebody, I would encourage them to, but also, we have to, on the system end, be sure that we are trying to look at the patient holistically, and whether that's, the different providers or just the physician or whatever. So.
Absolutely.
I agree. I think the physician or the physician provider, to a certain extent, they have a little bit of control over, their schedule. Yes, they have to meet a certain quota of people, but let's say on the initial visit, I may not be able to tell that, hey, this person has a lot of things that I need to delve into, but maybe after the second or third visit, I can say, hey, to the person doing the scheduling, for this person, I'm going to need more than 15, 20 minutes. I want you to block an hour for this person when they come in, and then the next person is scheduled after that. So I think some of the responsibility falls on the physician. And I think a good physician will realize that, hey, they have to tweak it a little. Yes, they learn about the disease, And, you know, we are taught about that it's a person as well, but I don't think as much time is spent on the person. So, you know, we were taught to take a social history, and a lot of doctors, unfortunately, do you smoke? Do you drink? Do you have sex? But not,
That's right.
you know, who do you live with? Do you have any pets? You know, what kind of work do you do? What kind of work did you do? You know, where were you born? And those are all a part of the social history that a physician is supposed to take when they're meeting a patient, particularly for the first time. Yes, it takes more time than just running through, you know, the more, I guess, less nuanced parts of the physical exam and history taking, but it's still important. One, it provides you with a lot of information. A lot of times that can help with treatment and diagnosis sometimes. So, you know, for those out there who are listening, who are in medicine or, you know, on that track, don't forget your social history. Talk to your patients about things other than their allergies and their current medications.
Because actually, you know, as you mentioned, like food, you know, I mean, you're having persons write them a prescription to take home, to take the medication, but your diet is a huge part of how you manage your medication. You know, and again, even the housing, if you have no stable place of residence, you know, the tracking or the tracing of that patient, you know, to chart their health wellness is impacted. So yeah, absolutely. Social support pieces are so critical. You know, I also want to add that it's, you know, for those listening, that the patient's voice is essential, because the patient is the expert on their own health. You understand? And so the doctor, the nurse, the healthcare provider is only as wise as the conversations that birth from the patient. So don't be afraid to speak up, or just to ask, as Dr. Emily said earlier, just ask questions that you might think they're trivial, but ask those questions, or even start with the big why, like why or how, you know, and that will get maybe the healthcare provider to provide more information, because time is also sadly a part of the equation, and oftentimes the health teachings get sidestepped. You know, the health teachings gets packaged on a piece of paper, and you hope the person will read these list of things, and they never get around to it, and they end up taking, you know, having what we call poor adherence or compliance to, be it medication or be it to the practices that we're trying to promote.
Quick question coming from the chat. Do healthcare and social service agencies communicate? Is there a requirement for health practices to have an in-house social worker?
Yes.
I don't think there's a requirement. Again, as I mentioned before, you know, it really comes down to funding, unfortunately. I don't know how things go in the US. Maybe Dr. Emily can speak to that. But here in Ontario, healthcare is funded by the government. And so there are different ways that doctors bill or are paid for seeing patients. And sometimes as a part of the community health center, they receive funding to hire a social worker. But if they don't receive funding to hire a social worker, then there's no requirement to hire a social worker. You know, I think there's a huge emergence of doctors that do prefer to work in the context of a community health center or a team, because, you know, a family physician only operates between this hour and this hour. But if you're functioning as a part of a team, then that, you know, improves the access to care, because the hours can be longer, even if you don't access your own family physician. They often have like after hours clinics. They often have other supports that are, you know, available to the patient. But it really comes down to funding at the end of the day, and how much funding they receive based on their roster of patients, and the type of system or the type of office that they work from within. So, and that also goes to, you know, speaks to, you know, a patient going in and asking questions. Like sometimes the doctor will explicitly say, I have one problem per visit, because they're billing per visit as opposed to being paid for, you know, the day. So they want to get as many visits in as possible. Like, you know, there's a lot of, you know, things in the background that are happening between doctors and their union and OMA and all this stuff, and the college that, you know, people aren't really aware of. So they might go in, and somebody who's already intimidated by, going to see the doctor, and already has an issue expressing themselves, and already doesn't have, a clear picture of what their symptoms are, they won't have the time, because some doctors are like, one problem per visit. What's your most important problem? So,
Yeah, just to add to that, so that's the public health perspective. To the question posed, within the healthcare system in the hospital, from the hospital perspective, the collaborative management team does often include a social worker, who oftentimes helps with the referral, especially for we call them elderly persons or older persons who oftentimes can't afford long-term care. They try to advocate for bed space and those sort of things. How effective it is more the question. Is it there? It's there in sprinkles, but how effective is it? Because once the handover happens from the hospital to the community, that's where the problem often happens. The person does need a support system after that. Having community nurses come or social workers come doesn't often, it's like a Band-Aid effect in part, but it does exist. That support does exist. You have a crisis nurse in the emerge, social support nurses, all that kind of stuff is there. But again, I believe it's the effectiveness of the role, because it really is only effective within the walls of the hospital. Once the handover happens, they go on to the next patient. They're not, the continuity of care is cut off right there. It just passed on to the long-term care or to whatever facility the person or services the person is referred to. And that, I think, is the issue.
I have a quick question about that. Are these, and it may sound silly, but in your experience, in all your experiences, are these social workers, or the people that they are, people who are helping these individuals, are they educated in cultural sensitivity and so on and so forth? Because that, I think, would be the big disconnect. Because yes, you can have a social worker in place, but if they don't know the inner workings of different cultures, it's all for naught.
Yeah, I mean, I jump on that one again. We have shifted from what we call cultural competency, as in we spent a lot of time educating healthcare workers on cultural competency. And now we've moved towards what we call cultural awareness. Cultural humility is the word, is to really understand, to be humble enough as a healthcare provider to really listen to the perspective of the person and their cultural beliefs, and make accommodations for that. It's not to say that you become competent, you're an expert now in the cultural nuances of each whatever particular group. And that's what the shift has been. I think where there is more of a structural setting, healthcare workers can come to the term of being more aware, of having more cultural humility. It's when you have, say, like community nurses or public health nurses, they function in autonomy. They're literally nurses, and they work independently, right, in the community. So if you're not doing your upgrades and you're following through, and you're not, doing your own self, learning, you can meet people where they are and not be as humble or as aware as you should be, and then it could be just how the region you're given to cover, again, we hear people wanting to go to, for example, long-term care that's only, I'm Italian, I only want to go to Italian long-term care, or I don't want to go Jewish, I don't want to go this. And so then there's a backlog of a wait list, and then also who are the social workers, who are the healthcare workers providing care for these persons, right? So, but yeah, we've shifted from competency to more awareness and humility, and I think I've observed from my little last 3-year experience in the nursing space, I'm seeing it actually in action. So I will say it's making some inroads, but more needs to be done.
Okay, Greg, I think you had a question from.
Yeah, well, there's a few things percolating. So one, and I'm gonna ask this, and I'm mindful that as I ask this, though we are talking to Tingz, we're not trying to get anyone in trouble either. So,
So I'm not
so you're
saying
allowed,
anything for this.
well, you're not going to pay for their salaries if they, anyways. So, so I'm being okay. I'm just gonna ask it because we're talking to Tingz and we're asking the Tingz. Vaccinations in our community right now. Our community is quite anti-vaccination. I'm getting a lot of things on WhatsApp and social media telling me, do not take this vaccine. Do not allow your kids to take this vaccine when it comes about. I'm an educator, and there is belief or the idea swirling around that we might be asked to take this vaccine before we go back in to schools or whenever it's developed, rather. What are your thoughts on the vaccine for COVID-19?
I'll say this about the vaccine. I know that law in this country cannot force anybody to take a vaccine that they don't want to take. I'm not saying, like, I say this because I've had this conversation many, many times.
Mm-hmm.
I don't know if they're going to change the Charter of Rights here, but human rights legislation cannot force anybody to take a vaccine at this time today. Will that change? I can't speak on that. But just like people can refuse the flu vaccine or the, meningococcal vaccine or whatever vaccines are usually given to children and babies as they're growing, which I took, and look at me, I'm okay.
Yeah.
And I know many people who took them.
Sure.
I know that right now there's more of a trend of people that are choosing not to vaccinate their children, and their children are still allowed to go to school. So there's a bit of a different process for them to go to school. Instead of just providing a vaccination record, they have to fill out some forms and do some extra things, but they get to go to school. So I don't see a reality where, you're going to be forced to take a vaccine for COVID-19. Like the way the law is written in Canada right now, it can't happen. So I know that that's, again, something that's floating around, and they're going to put a microchip and this and that and the 5G and, all this stuff. But the reality of it is the legislation, which I spent years studying, says they cannot force it.
And just the good doctor might speak on this, of course, but just to be very clear to the public, the vaccine by definition, really, it's a substance that is used to create antibodies, these things that will help you to build your immunity against a particular disease. So it's unfortunate that the narrative has changed where the vaccine word has become a negative thing. It's actually a good thing, for what it's meant to do. Now, the question is the specificity, or not use as fancy words, is it a good serum? Will it be harmful? Yes, will it be harmful? Is it effective enough? And I'm not going to advocate, or I will say that I particularly wouldn't want the first iteration. I would want, maybe the 12th or 13th. As the jazz song says, 7 steps to heaven. I want to take all 7 steps to get there. You know what I'm saying? I don't want us to go in heaven right away. But yeah, I think it's the distrust around the surety of the thing. Will it do the job it says it should do? And unfortunately, there's been all of these cases, where vaccine has been linked to so many other things. But COVID, I think I'm only concerned for the race for the vaccine, and then how effective it will be. And then we will see how it's distributed to what particular group to start out. All right. We'll see how that works. But I think I'll let Emily jump in on that part.
I agree with you, Jeff. I don't want the first one. I'm talking the things now, all right? I'm going straight up honest. I don't want the first one. Okay.
That's right.
Yes, Dr. Pakwan, yeah.
I don't. I mean, I don't know. I think it depends. You know, is at the point where I'm being posed the opportunity to say yay or nay to the vaccine, is it still in its study period where we don't know if it works or what the side effects could potentially be? Or has it been proven that, hey, this is going to help you build your immunity against the virus and help you either, you know, prevent getting infected, or if you are infected, prevent you from being severely infected, which is the case for the flu vaccine, for those out there who are not flu vaccine proponents. Okay. It prevents you from, or helps prevent you from, getting severe infection, but I digress. So that would be my concern. Is the vaccine still in its study period where we don't know, you know, how it's going to affect persons, or is it been proven and you know, is it now going to be like a public health issue where we know that this prevents you from getting infected, and it's, you know, kind of like measles, or, you know, that would be my concern. Like, where are we in the stage? I think right now, obviously, we don't have a vaccine. It's going to take a long time to develop a vaccine and then have it, you know, run through the iteration of tests that vaccines normally are run through before it can be deemed safe enough. So I am not, you know, I wouldn't say or encourage someone to, at the back end of it, when we've gone through all the proper testing, I wouldn't, depending on how it turns out, that would determine how I would then advise people. I don't want the first one though.
Yeah, you know, and you know, you know, not to make light of the question, it's really actually a multifaceted question, because it's also, when you look at, once the vaccine comes out, you have to see the frontline workers, right? The persons providing care, they need to be protected. Right now, we're using PPE to protect us. We're using mechanical things to protect ourselves. We're not using a biochemical agent to protect ourselves, right?
Right.
So you think of frontline workers who would be up for the vaccine. You think of the most vulnerable of our population to be up for the vaccine. You know, you're looking at, when frontline workers, meaning teachers and, you know, firemen and paramedics, and it's all the spectrum. So again, and then you look at the general public. But there's also a legal piece to it, because say you're with an organization that says, you know, we implore you to take the vaccine, and if you don't, and you should become sick, you will not get any money from us. You know, you will not get any coverages. You can't sue us for anything, because even right now, if you don't take the flu vaccine working in the hospital, if you get sick on you. You know, so unless you're a full-time worker, you get time off paid with sick day with pay. And it's actually been a big thing now in the politics of what's happening right now with persons being out of work. Should people get paid while at home or paid while sick leave pay? And the same thing. It's a very interest for unions, for all those facets. It's that whole vaccine. It's a monster topic to deal with. You know, it really impacts a lot of areas
by itself.
Yes. I just want to clarify something before I shoot it to Greg for the last question. Earlier, when I was talking about the Tuskegee experiment, all the words left my head. So I just want to clarify something. It's not that they were given syphilis. The syphilis treatment was withheld. So I just, for anyone who is looking out there, we want to give out accurate information. As I said, head gone. But off to you, Greg.
Okay, so the last, thank you. So the last thing I wanted to talk about was healthcare literacy. So on our last program, we were talking about education, and a lot of the viewing audience was asking, well, listen, how do we speak to educators in order to get the best outcome for our children? And I feel like we could sort of apply the same thing to healthcare. Healthcare literacy, I know, Jeff, we were on another program and you talked about this. So I want you to weigh in on it, but I want everyone else, both Cheryl and Emily, to weigh in as well. Healthcare literacy, how do we know what to say, what questions to ask when we go in to speak to medical professionals? You guys touched on it before. I think someone said, no question is a dumb question, right? But if you could just give us a little bit more where that's concerned, as well as maybe even if you have any resources that you want to share really quickly as we're closing up here. We have about 5 minutes left. If you could, each one of you, just tell us a little bit about healthcare literacy and some resources that you might offer to our viewers as well.
All right. So I'll jump right in with, it's really, really, really ghetto because I do a lot of research. So if you can see it there, I'll send it in the link. It's racism and health equity. It's a great packaging from the National Collaborative Center of Determination of Health. It's actually a Canadian body of work that encapsulates everything we're talking about right now. So I will definitely get it to the moderators and hopefully it can be accessed. To this question of health literacy, if you remember the simple things like the when, the why, and the how, start with that. You don't have to go into any communication course as to like open-ended questions, close-ended questions, and all of these complex pieces. Just remember that you can always ask, okay, when? Because in the nursing process, we always like to know when things start, and so you have an idea of when something is happened, or and then why you think it happened and how. These are good starter places for questions. Using those when, why, and how is always a good thing in terms of literacy. And take the time. I mean, I hate to say people that have become Google doctors and stuff, but there's nothing wrong with Googling stuff, but make sure it's evidence informed. Make sure it's linked to some research or multiple research sources. And then it's okay to ask the doctor. I will say, the thing, don't go talking to the doctor like you are the expert,
Yes.
The posturing you might be thrown off. You might throw the person off, there's a humility that comes with how you speak about your own health concerns, right? So yeah, I often get the issue with my own tone and the texture and of my voice. These are things you got to think about, consciously. But again, go back to the when, the how, and the why, and still do your own research. It's okay to Google things and look things up. If you can't have a phone or a computer, you can go to the public library, because these are also determinants of health. If you can't access the technology, you can't, or get someone, a younger person, to do the research for you, and again, help you to understand the language. All these pieces really help with building your own literacy. And then when you finally have the front facing with the physician or the healthcare provider, you can then at least articulate what you're trying to convey around your situation.
Thank you, Jeff. Thank you. Cheryl, you want to jump in and talk to us a bit about literacy?
Healthcare literacy is obviously very important for anybody, but specifically in the Black community, we need to be a little bit better at self-managing so that when we present to a healthcare provider, we're able to adequately articulate what is going on with us. If you understand your symptoms, if you understand this is not how I normally feel, and are able to communicate that to a healthcare provider, then hopefully that healthcare provider is well enough to help you understand what's going on. So there's the ability, as what Jeff said, to access information. So, how are you doing your research? Where are you getting your information? What is the source of your information is really important. It's not that, you just Google anything and take anything at face value, but you have to be really aware of where you're getting the information or the source of the information, your understanding of that information. And if you're not able to understand, ask people around you, ask somebody else to help you and decipher the information that you find. Evaluate. So what does this mean? Okay, I Googled this person explained it to me, but what does it mean? What does it mean if my blood pressure is high or low or, whatever? What does that mean? And then communicate, like I said before, to your healthcare provider as best you can. And once you are able to access, understand, and evaluate, then that makes it easier to advocate for yourself too, because you have a good understanding and you can be firm in your understanding of your own health and your own condition.
Thank you. Thank you. Emily, last word. Your thoughts on literacy, as well as if there are any resources or anything. And Cheryl, too, if there's any resources that you have, please feel free to throw that in there.
Before sorry, just the Public Health Ontario, I know, has a lot of resources on health literacy. It's one of the ones that I draw from a lot as a healthcare provider, because it does remind you of even that self-management support as a provider. Like, how can I ask the questions that will get the answers that, you know, we'll both be able to leave with an understanding of what happened. So my apologies, Emily, go ahead.
No worries. I think healthcare, increasing healthcare literacy, I think part of it starts with, you know, I think Jeff indicated earlier that, you know, a lot of times people have issues engaging with a primary care. But I think having a primary care provider, someone that you see, I would say relatively regularly, would be part of developing healthcare literacy. A lot of times we find patients who engage with the healthcare system are more literate. Unfortunately, a lot of those patients have chronic illnesses. So a lot of times we notice that children who have cancer or who have longstanding chronic illnesses like sickle cell disease or type 1 diabetes, they actually are very aware of their disease and how it affects them and what the treatments are and what they need to do, et cetera, et cetera. And a lot of times we're actually taught as medical students and residents that, that patient will really know more about their disease than you could ever tell them because they've lived it. They're living with it and they've gone through multiple iterations of it. So, I think that all goes to say, again, engaging with the healthcare system. And I think something as simple as getting a primary care provider, if you can, would help with that. Asking questions. I'm a big proponent of asking questions. I encourage people, patients, ask questions. It doesn't matter how silly you think it is. I think a good physician is going to let you ask the question, and if they can provide you with an answer, they will provide you with an answer in a way that you understand. And if they can't, if they don't know, they will be honest with you and say, I don't know, but you know what, next time I'll look into it. And when you come back, we'll have a discussion about it. I think getting a physician that you have a good rapport with, that's gonna be, I think that's vital. Setting a good foundation will help with the literacy aspect as well. They listen to you, you listen to them, you ask each other questions, and you learn from there.
Hey, awesome.
This is really good.
Thank you so much.
No, I was
thank you
saying that there's so many things that we didn't even get to touch on in this time frame, but who knows? There's a part 2 on the horizon.
Yeah, gender-based, health. Because we said Black folks, but Black men and Black women approach healthcare very differently. You never thought the thing next time.
Yes, there's a whole.
The whole thing right there.
Whole thing there. But yes, Greg, I'll let you wrap up.
Intersectionality.
That's right.
So I just want to say thank you all so much. You guys shared a wealth of information with us. And I just want to also let everyone, viewing audience, know that this is going to be archived. So you can go back and watch this. So if you didn't catch everything, please feel free to go back and watch this again. It will remain on our YouTube channel. And please tell others to watch it. Listen, while I was speaking, my phone here was blowing up. People were messaging me about what you guys were saying. So you guys, you're setting it off in the YouTube chat as well as my phone here. So people were very much engaged in what you had to say, and you guys just shared, as I said, a wealth of information with us. When would we get to sit down with people who look like us and just hear all of this wisdom being spewed and coming at us. Thank you guys so much. And again, it's very empowering for me to see all of these Black healthcare workers. Again, we often see one side of Blackness, and it's very good for us to show this multi-dimensional portrayal of who we are. 2 weeks from now, Black mental health, and this is something that we need. Yes, Camila's clapping. We have to talk the things on that one, right? Because it impacts so many people. Everybody, I think all of us can say that we know somebody, if not within our family or us ourselves, who are experiencing challenges where mental health is concerned. And we're going to talk about that in 2 weeks. Thank you, Jeff. Thank you, Emily. Thank you, Cheryl. Thank you, Camila. And thank you to everyone who hung in there with us for an hour and 20 minutes. Thank you so much. I think it was time well spent. God bless. Take care of yourself. We'll see you again. Talk to Tingz. Is it?